At the outset, I'd like to thank ISA Thrissur for giving me an opportunity to present a talk on the facial plane blocks, the evidence, and the controversies. Regional anesthesia has witnessed major advances from the olden days where we used to practice landmark guided nerve blocks, where we had a hit or miss approach, which was improvised by the advent of peripheral nerve stimulators. And the introduction of ultrasound guidance into the clinical practice of regional anesthesia has tremendously improved the clinical effectiveness and safety of our nerve blocks. Epidural and paravertebral blocks are still widely practiced for postoperative analgesia, but these are associated with several complications due to the invasiveness of these procedures. So the past decade has witnessed a paradigm shift towards minimally invasive regional anesthesia, with the answer to which was the facial plane blocks. Now, these blocks have been embraced enthusiastically. In traditional peripheral nerve blocks, we have definite neural endpoints. That is, we see a nerve and try to deposit the local anesthetic as close to the nerve as possible. In facial plane blocks, there are no neural targets. The local anesthetic is simply deposited in a plane between two anatomical separate layers of fascia. So several facial plane blocks have been described, and they have been largely imbibed into our clinical practice without much thought being applied to how these facial plane blocks provide analgesia, or what are the advantages or rather disadvantages of these facial plane blocks, and whether these blocks can replace epidural blocks in their routine clinical practice. By the end of the discussion, I hope I'll be able to answer a few of these questions. So this image shows the course of a spinal nerve. Once it exits intervertebral foramen, it splits into an dorsal ramus and a ventral ramus, which proceeds anteriorly to split into the anterior and lateral cutaneous branches. Now, various facial plane blocks target the same nerve at different points. Now, despite their popularity and widespread acceptance, they have their own fair share of controversies. Compared to the traditional peripheral nerve blocks, these facial plane blocks do not demonstrate dense neural blockade. There is variability in the results obtained in individual patients itself. The cutaneous sensory blockade underrepresents the observed analgesia. I will be discussing more on this in the coming discussion, and the validity of the available evidence is highly questionable. So the major drawback of these facial plane blocks is inconsistent analgesic effects. So to understand that, we must understand the proposed mechanisms of action of these facial plane blocks. Now, this is largely controversial. Two plausible mechanisms of analgesia are proposed. One is by the local effect on the nociceptors and neurons within the facial plane. And the second one is by the systemic analgesic effect mediated by the local anesthetic drug that gets absorbed into the vascular system. So as I already said, what we do is we deposit a local anesthetic in a facial plane, and we intend that local anesthetic drug to spread in the plane and act on the clinically relevant nerves. For example, we target the lateral cutaneous branches of the intercostal nerve in the PEX2 block. Another proposed mechanism is by the spread to the adjacent compartments. For example, a component of the analgesia provided by the ESP block is thought to be due to the action of the drug that spreads to the epidural and paravertebral spaces. So local anesthetic spreads by the method of bulk flow driven by the pressure gradient of the injection, or by the process of diffusion driven by the concentration gradient. Now, this diagram demonstrates the caudal encephalad spread of the drug from the injection point. And the systemic analgesic effect is produced by the local anesthetic, which gets absorbed into the vascular system. The drug deposited in the facial plane enters the vascular system and gets transported to distant sites to act on the pain pathway. Now, this mechanism is considered largely plausible because of two reasons. Now, the first one is the large amount of the local anesthetic drug that is used in these facial plane blocks. And the second one is a widespread acceptance and use of intravenous lignocaine infusions for providing perioperative analgesia. So ultimately, there are three possible fates for the local anesthetic that we deposit in a facial plane. It can either spread out and remain within a facial compartment, or disperse out of plane into adjacent muscles or compartments via facial openings, or diffuse into blood vessels and provide systemic analgesia. So this study explored the intra-individual variation of the TAB block. And what they did was they administered TAB block in the same patient by the same practitioner 48 hours apart. And they looked into the sensory blockade. And they found high intra-individual variation in the blocked area. And Latsky et al. Explored the pharmacokinetics of the ropivacaine after TAB block in healthy volunteers. What they did was they performed TAB block with ropivacaine, and then they placed microprobes with sites caudal and cranial to the TAB block site to measure the ropivacaine concentration at these sites, and also measure the plasma concentrations of the ropivacaine at different timings. Now, what they found is there was very, very high individual variability in the ropivacaine concentrations measured at different sites, and though the plasma concentrations remain highly comparable. So these two studies itself demonstrate the inconsistencies and the spread of the block. And to understand why this happens, we need to understand the anatomy and physiology of fascia. So it is composed of soft collagen containing loose and dense fibrous connective tissue. It permeates through the whole body and has three layers: the superficial, deep, and the muscle-related fascia. So the deep fascia is the target of the facial plane block, and it has several functions, including maintaining posture and force transmission. So the variability in clinical effectiveness of the facial plane blocks is already evident, and this variability is multifactorial. It is just not enough that the local anesthetic spreads and to reach a target nerve. What is more important is that a minimally effective concentration also should reach, and this concentration will determine the clinical effectiveness of the analgesia. Now, the spread of the local anesthetic is influenced by various anatomical and physiological features of the deep fascia. So the factors that affect the local anesthetic spread and the factors that contribute to the block inconsistency may be due to the variations in facial structures and the facial function, or the variations in the nerves themselves. So there are different types of deep fascia. It may be epimysial or aponeurotic. The aponeurotic fascia is thicker. It is easier to identify in the ultrasound, and it prevents the spread of local anesthetic and containing it within a compartment. Example, the thoracolumbar fascia. Whereas the epimysial fascia is thinner, it is difficult to locate and target. It will allow easy spread of the drug. There is also the difference in numbers of layers of fascia. For example, the chest wall pectoral fascia is single layered, whereas the thoracolumbar fascia has three layers. Now, it is not really known whether there is an optimal layer where the drug should be deposited for the best results. Now, the lines of fusion are sites where the fascia fuse to create a compartment and contain the local anesthetic drug. The linea alba is a well-known example. It prevents the spread of the drug from one side to the other, which makes it mandatory that bilateral rectus sheath blocks are given for a midline incision. Now, pathological lines of fusion can form from adhesion formation after surgery or trauma, and these can act as roadblocks for the spread of local anesthetic, thereby contributing to inconsistent blocks. Now, this is a concept totally opposite to that of the lines of fusion. Many facial planes are continuous and communicate with each other. For example, the thoracolumbar fascia is continuous with the endothoracic fascia through the medial and lateral arcuate ligaments. So theoretically speaking, local anesthetic drug given for the ESP block here can spread all the way to reach the plane deep to the pectoralis major. Now, local anesthetic can spread in several directions along the path of least resistance. It can result in an unpredictable extent and direction of spread, which is beyond the operator's control and can contribute to block inconsistency. Another facial function of gliding does affect the local anesthetic spread. The fascia glides over one another, and this ease of gliding is influenced by hyaluron. The thoracolumbar fascia is more mobile than other fascia, and the muscle contractions also affect this facial gliding. Other factors that may influence the spread include the patient position, the ventilation, the muscular contraction, and several other technical factors. That said, coming to the next controversial area is the absence of cutaneous sensory loss. Now, in case you give us a supraclavicular nerve block, if you want to know that if the block has acted, you try to check the loss of pinprick sensation or the cold sensation. And if the patients cannot feel both of these sensations, you are assured of an clinically effective block. but no such cutaneous sensor. The cutaneous sensory loss is not really congruent with the analgesia that is observed in the facial plane blocks. Now, some theories are put forward for this. One is that the fascia is a sensitive organ and is richly innervated. The muscles and joints are also densely innervated, and these nociceptors transmit physical stimuli like mechanoception and proprioception under physiological conditions. But under conditions of inflammation induced by the surgical trauma, these are, nociceptors are upregulated and they cause hyperalgesia. And blockade of these upregulated nociceptors is said to be one mechanism of action of the facial plane blocks. Then there is a concept of the fasciotome. The innervation pattern of the fascia is described as the fasciotome. This fasciotome is more closely related to the underlying muscles, the myotome, rather than the overlying skin, the dermatome. And the fasciotome map has yet not been described. So the direct anesthesia of the fascia rather than the blockade of the cutaneous sensory nerves is said to be the mechanism of action of proposed mechanism of action of the facial plane blocks. And this theory might provide an explanation for the absence of cutaneous sensory block. This again confounds the policy, the principle that how we can assess the efficacy of the block. If there is no cutaneous sensory loss, how can we define the success or failure of a facial plane block? Now, coming to the evidence, all these theories have been based on evidence derived from the cadaveric studies and the imaging studies done in volunteers. But the nerve staining in cadaveric studies or the dye spread in the imaging studies provide little information on the injectate concentrate. It may show that the injectate is spreading to this level, but it can never show what concentration of local anesthetic is actually reaching the targets. So extrapolating evidence from the cadaveric and radiological studies must be done with caution. So the final question is, can facial plane blocks replace epidurals or paravertebral blocks? Now, this is highly doubtful as of now, though several studies have been published to prove the clinical efficacy of the facial plane blocks. Few studies have compared them to the traditional epidural and paravertebral blocks. So more research is needed to completely bring them into the guidelines. So I believe ESP for breast surgeries is one of the most common facial plane blocks, and we believe it is very effective. But this meta-analysis looked into the clinical effectiveness of the analgesic benefits of ESP for breast cancer surgeries, and they found out that adding ESP to parenteral analgesia provided statistically significant but clinically unimportant short-term benefits. What they found is that this statistically significant result was the opioid reduction in the opioid consumption, which amounted to an equal of 0.73 mg of morphine of oral morphine per hour. Now, this was a very modest short-term benefit compared to the risk of complications like pneumothorax and local anesthetic toxicity that can happen with ESP. So they recommend that the current evidence does not support the routine use of ESP and should be considered on a case-by-case basis. So in this BJ editorial, Maroffer reminds us of the simple paradigm of regional anesthesia to put the right dose of the right drug and in the right place. And he reckons us wherever possible, we should not return to the hit or miss approach of the regional anesthesia, which was practiced way back in the times of landmark guided approach of the regional anesthesia. So for future research, we need to find out the optimal site, plane, and the speed and pressure of injection for providing consistent blocks. And for the take-home message, facial plane blocks are associated with unpredictable spread and inconsistent clinical effectiveness. We have a long way to go before they make place in guidelines. Now, why do we need them in our toolkit? Because radial anesthesia is a part of the multimodal analgesia. They are simple and easy to perform. And because of their ease of performance, they may help to popularize the use of regional anesthesia. And they can act as a plan B where epidural is difficult or has failed. These are my references. Thank you for your patient listening.